All right, so I'm going to talk about some simulations and projections of COVID-19 that we do at population scale. I'm going to acknowledge my collaborators first. A lot of this work has been led by Dr. Sen Pei, who's an associate research scientist in environmental health sciences at Columbia. Other collaborators are listed there, both within Columbia Mailman as well as other institutions. A lot of our thinking actually came out of a field study that we were doing in Manhattan called the Virome of Manhattan. It had a number of objectives, one of which was to try to understand the gross prevalence of respiratory viruses generally in the population, how they're circulating, and what the rates of asymptomatic infection were. One of the arms, we established a 214-person cohort from October 2016 to 2018. We asked all individuals in the cohort to provide us a daily assessment of their symptoms with respect to 9 common cold symptoms, like runny nose, sneezing, cough, sore throat, chills, etc. And they would rate that on a Likert scale from none, mild, moderate, or severe, enter it into their cell phone and go into an electronic database we've kept. They would also tell us on a daily basis if they had taken medicine, stayed home from work or school, or gone to see a physician because of their respiratory symptoms. So that gave us a very nice long time series record of what was going on with them symptomologically and in response to their symptoms. We also once a week would swab them irrespective of how they felt. Over the course of this study, and not everybody was in it for the whole length of time, we recorded a number of infectious episodes by a variety of different viruses that we tested for, which are listed in this table. Infectious episode was a group of consecutive weekly specimens from an individual that were positive for the same virus. We did allow 1-week gaps to account for false negatives or temporary low shedding. And you can see that the range of infectious episodes we got, ranging from 20 for human metapneumovirus up to 275 for rhinovirus. But you also see that there's some conditional probabilities there. And that is, MA stands for medically attended. PMA, given a virus, it gives you what's the probability of seeking medical attention given that you had a virus, the same thing for staying home, and the same thing for taking medicine. And what you notice is that the probability of actually seeking medical attention for these respiratory viruses is quite low. Even for influenza, it was less than 1 in 4. The weakest one were for the endemic coronaviruses, where it was 1 in 25. And what that informed us was that there's a lot of virus going around, and that most of it is undocumented, and that there is a lot of opportunity for transmission because people are shedding viruses broadly in the community. They're out and about in it. And it's for the reasons that most of us understand. That is, when the wintertime, if we get a runny nose or a sore throat, we still go to work. We still go out and go shopping. If we have a business trip, we'll still get on an airplane and we'll go from place to place. And we're bringing the virus out in the community. We're spreading it to new locations or geographically translocating it. So given this, when we saw this virus emerge coming out of Wuhan, and then the way it rapidly spread within China, and then geographically translocated to Thailand and Japan, the US, and other countries, we got a sense that this had to be a virus that was possibly supported by a lot of silent transmission, that there may be a lot of undocumented infections out there, and that those people may themselves be contagious. So what we decided to do was to build a model inference framework to try to identify what those levels of undocumented infections were and how contagious those undocumented infectious persons were relative to a documented infection. This is a metapopulation model that we built that represents the transmission of the virus in 375 different cities. We used 10-cent travel records during the run-up to the Chunyun Spring Festival to actually inform the movement of people between locations. So this is a location-based service pulled off of people's cell phones from very popular applications such as QQ and WeChat that have enormous penetration in Chinese markets. So it becomes a fairly high-dimensional model because we're running it in 375 cities. We coupled this with data assimilation methods. These are Bayesian inference algorithms that allow you to do state space estimation, or in this case, parameter estimation for the system. And we were very interested in the parameters. We used that data assimilation in conjunction with observations of daily confirmed cases from 375 cities. And we focused on a period from January 10th to January 23rd in China. So this is at a point in time beginning January 10th when the cases were much less sporadic. They were really ramping up, so there was more of a signal of what was going on with the virus. And it stops at January 23rd because that was the date in which they imposed travel restrictions and control measures. They shut down travel in and out of Wuhan, and then just a few days later across much of China, and they put in heavy control measures. Now, within the model, we're separately representing documented and undocumented infections, all right? And we have a separate contagiousness for the documented and undocumented infections. And what we're going to be trying to do with this model, which is stochastic, is to estimate the parameters that are in this system. There are 6 of them. Before we actually applied it to data, we do what we call a synthetic test of this, where we use the model to generate simulations of an outbreak using prescribed parameters. It's run stochastically. It produces an output that has cases in it over time. And we then take that output and we plug it back into the model inference system and see if, without giving it what the parameters were, it can recreate them. And so what you're looking at here is one example of the synthetic test on the left. It shows the 6 parameters in the model. Beta is the force of transmission, it's the contact rate for documented infections. Mu is the adjustment of that for undocumented infections. It ranges between 0 and 1 typically, though presumably undocumented infections could per person be more contagious. It's possible. Theta has to do with the movement or the spread. Z is the latency period. Alpha is the ascertainment rate. What fraction of infections are going to be documented? And D is the infectious period. On the lower right, it shows the estimate of the reproductive number as well. The reds are showing the truth, and the histograms here are showing the distributional estimate that we got for this one run at the truth. And you can see that it's capturing within the credible intervals, the 95% credible intervals, all the truths. And we did this many times, and we did it with lots of different combinations to see if it was robust, regardless of what parameter combination was thrown its way. We also deconstructed it down to smaller systems to see how using more and more cities was beneficial for the identifiability of this problem. So once we were convinced that this was working, we actually applied it to the real data. And this table shows you the results that we got here. I want you to focus primarily on mu and alpha. So alpha is the reporting rate. You can see it's 0.14. That means we're estimating that 14% of the infections were documented during this 2-week period in China in the run-up to the control measures. This is a period of time when the virus was moving about relatively unconstrained, as it were, moving in its natural state, if you could think about it that way. In addition, what that means, of course, is conversely that you're going to have 86% of infections are undocumented. In addition, we found that per person, the undocumented infections are about half as contagious as a documented infection. However, there are many, many more of them. First thing we want to do with this is plug the parameters in and see if in free simulation, we're able to capture observations. And indeed, we were able to do so. It shows you the X's nationally daily cases, cases in Wuhan city, and cases in the Hubei province in which Wuhan resides. And you can see that the simulations here, representing multiple stochastic simulations as box and whiskers, are spanning the observational space. Again, it's showing you the distribution of the estimate of the reproductive number that we got, which was 2.38. And on the right, it's showing you a similar plot of the number of cities with cumulative incidence greater than 10 and how the model is capturing the geographic spread as well. Now, because it's a model, we can play around with it a little bit, and we can ask the question, well, what if these undocumented infections actually had not been infectious? What would that have done to the degree to which this virus would have spread geographically and exploded within China during this 2-week period? To do that, to test it, we just set mu to 0 with all the other parameters set as fit, and we run the model again. And what we see when we do this is that we lose about 80% of confirmed cases. They're gone. What this is indicative of is that these unconfirmed, undocumented cases are really responsible for the lion's share of transmission. They're what are supporting the chains of transmission, allowing the virus to spread geographically and to spread within communities. We also found estimates based on our inference that there was some considerable length of time where there was pre-symptomatic shedding amongst these people. Now, I should stress that the undocumented infections does not mean they're asymptomatic. That is not the dividing line we're using. It's documented versus undocumented. Undocumented includes people who just avoid clinical care. They may tough out severe illness at home. It includes mild symptoms, and it includes asymptomatics. So when we look at this and we think about where this lies on the spectrum of the coronaviruses, it falls right between where seasonal coronaviruses, the endemic coronaviruses lie, which produce those mild infections, Shows you our data from the Virum, 135 infection events, 60% mild or asymptomatic, and only 1 in 25 seeking medical care. On the other side, you had SARS, which had no pre-symptomatic shedding, and subclinical infection rates were believed to be very low, if not zero. Can't identify people who were undocumented infections. MERS had a little more in the case of mild and asymptomatic infections, but it wasn't very transmissible and it could be circumscribed. So what it indicated to us that this virus has the features that make it a pandemic. It's got the perfect combination. It is an emergent, unknown virus to which the majority of the population of the world has susceptibility. The majority of its transmission is going to be supported by undocumented infections who are the preponderance of it, and they support stealth transmission of the virus, which makes it very difficult to control. And lastly, it has a fat tail, where there are a substantial number of people for which this is not mild, and they have serious or critical complications associated with it, and there's a substantial fatality rate. So we turned this model and we then applied it to the United States. Instead of doing it at the city level, we did it at the 3,000 plus counties of the United States. We ran an inference for the whole United States and we made projections using the parameter estimates we had. First one we did was through March 13th and we made projections through the summer, which is a very long period of time, which we generally issue, but we did this to test it out. And we also tried what would happen if we could reduce transmission 25%, 50%, or if we could reduce inter-county movement by 95%. What you're seeing here are the results of those in just a static shot as to what incidence would look like on June 20th, 2020, which was 3 months in the future at the time. To show you what the parameter estimates were for the United States initially, they were actually quite consistent with what we saw in China, excepting the reporting period, which was actually substantially lower. Instead of being about 1 in 7, it's about 1 in 12. Which meant that the United States was documenting fewer of its infections than the China, if you're going to believe this model estimate, and that is consistent with the limited testing availability and how the United States wasn't pushing a proactive testing approach at the time, and still really isn't, to be honest. The relative transmissibility is a little bit higher, but that may be expected if some of the more serious cases or infections are not being documented. By the way, this transmissibility of being 0.55 for undocumented or 0.64 here is indicative that there is some relationship between symptom severity and contagiousness on an individual level. More recently, and this is our latest projections using data as of May 2nd, we've had to consider
2 minutes.
Okay, we've had to revise our projection scenarios. We have to assume what people will do, and we don't always know what it is. We've tried a variety of them. It's highly speculative, and you have to look across a number of different scenarios because, you know, these really aren't forecasts. We don't know what people are going to do. This shows you how we've responded to the fact that states are opening. As of Sunday, it was 25 states that had or were planning to reopen. It's now 31. We worked with the 25 when we did this 3 days ago. And what we did is we had this strangling of the virus in places where counties where there was growth of cases, sort of this reactive social distancing and increase in compliance of social distancing and mask wearing, where there's an immediacy that the virus is in your community and growing. But this is superseded in the states in which they do this loosening, where we either put a 10% bump on the latest estimate of the reproductive number or a 10% bump per week, which is reflective of the idea that as they open up a bit, people get more and more comfortable with it. At first, they don't frequent businesses, but then they do more and more so. This is the result of what we're seeing there. For the one time, it's in red. For the multiple times in these states, this is blue. This is showing you the whole United States, total cases and total projected deaths. The concerning feature is the fact that there's a delay baked into the system. People acquire the infection and it's 2 weeks before they're confirmed. It's 3 weeks plus before they may die from it. As a consequence, what we do today to loosen restrictions, we are not going to see the consequences for a couple weeks. And then we're going to have some exponential growth baked in if exponential growth is indeed taking place. And this is what we're seeing. Projections where in a few weeks, we may start to see rising cases and deaths in the United States as a consequence of this. Just to show you some estimates of the reproductive number, look at the lower left, and this shows you another model's estimate of it at national scales, New York, New Orleans, and Los Angeles. We're hovering around 1. I'm going to go back and just point out, in this plot here, it shows the reproductive number at 1. in red there. And it shows the estimates on May 2nd that we have for this model. We're doing projections for the counties in each of these states, represented as box and whisker plots. You would like them to be well below 1. That is not the case. Some of them are straddling it. Some of them are considerably above it, yet still reopening. Places like Tennessee, South Carolina, and Indiana, they're not in a position of strength where they should be really considering reopening as of yet. Lastly, we did a counterfactual where we looked at what would have happened if we had done the control measures we've seen, which is actually estimated through time by these reproductive numbers dropping on a daily basis you see here that we have on a county by county basis. What if we had imposed that drop 1 week earlier or 2 weeks earlier through some concerted federal policy? What you can see here are the results both for national and New York City metro area in terms of reductions in cases and reductions, that's confirmed cases, and reductions in deaths. The red dots show you what actually happened for each of them. And you can see that there is almost if you move it back to March 1st, there is almost an order of magnitude reduction in deaths just from a 2-week earlier manifestation of these control measures. I'll stop there.
Thank you, Jeff. This was obviously an extremely interesting talk, and affects all of us. Let's see if there are questions. Alexander Van Green.
Lex, go ahead.
Yes, hi Jeff, thanks. I heard a similar presentation, say the first 80% by you a few weeks ago, and that was before the reports from before reports about underreporting of fatalities in Wuhan and then other parts of the world reached the papers. I was wondering to what extent your predictions are sensitive to what has been reported since.
Right, so underreporting of fatalities is something that we, if it's a consistent bias to the system, we will do all right. We will be predicting biased results in our estimates, and we will have to work with that bias work. The problem is it's not consistent. It's non-stationary feature, and it's difficult to account for. At the time period for January 10th to 23rd, we do believe it was relatively robust in what the reporting was. I don't think there was as much suppression of information as we saw once they imposed those travel restrictions and control measures, and we've certainly had intermittent reports of that. However, if it is off the rails, it is very challenging. And that, brings up issues that there are going to be biases in this. And obviously there are also biases in things like estimates of the attack rate or the ascertainment rate, or alpha, through seroprevalence surveys. Those have real problems if there's, specificity issues in the test in particular. So, in all of these things, we're dealing with real incomplete data that is not as good as we want. Certainly, one would hope that the death data was a little more reliable in many countries. It will be biased low. There will be under reporting, but it may be more consistently that. Whereas the case data has some problems because testing practices differ over time. Those are issues that we just have to think about and adjust for and deal with explicitly in our model framework, or try to, by adjusting the observational error variance that we associate with those observations.
Thanks, Jeff.
Thanks, Jeff. And Darcy Kelly?
So I have two questions. Did I understand that your estimated R0 is one, that every infected person infects one other person, or is it higher than that?
This is when we talk about R0, our initial R0 for the period of time in both the US and in China was about 2.3 to 2.4, which was in line with the estimates at the time. More recent estimates, some people have said it's higher. We recognize that it's variable. If you don't account for undocumented infections, you're going to be biased high in your estimates. So some of those results of recent have also been flawed, I would argue. But what we're talking about here, when you see this is a measure of what's actually going on based off the data here. And this is the effect of social distancing over time that you're seeing in the lower left, as you're seeing New York and New Orleans and Los Angeles and nationally, the rates drop. So we're estimating it over time and using it as a measure to pull off from the accumulation of cases, how social distancing has affected it. So it is being quite effective in reducing contacts and reducing transmission opportunities, and thus consequently dropping what is really the effective reproductive number.
So we have two more questions, and we'll have to move on to the next speaker. So Neville Klein.
Yes, hi. I was wondering if you have any quantitative assessments of how expansive the trace and quarantine techniques would have to be to adjust your models.
You know, we haven't tried to model that explicitly. And so, but I look at it from this perspective, which is that if we were to look at a country that has been able to really quash an exponentially growing outbreak, and that would be South Korea, and they provide the best example. Their ratio of testing to infections identified is 60-1, and ours is 6-1. So we're an order of magnitude off. We've done many more tests, but we have 100 times as many infections as South Korea has experienced. If you're really going to get on top of this and do it aggressively and penetrate into the community well, you're going to have to ramp up your testing. Now, I don't know if we can get to 10-1 at this point, increase it by an order of magnitude. But that would need to be done, and it has to be accompanied by contact tracing and isolation and quarantine that is actually effectively imposed.
Okay, last question by Margaret Cosial.
Hello, thank you so much for your talk. I happen to have gotten stuck in a red state. I'm in Alabama. And I was just curious, have you all done anything that looks at sort of population center hotspots? What I'm observing here is that, you know, it is almost in some respects like this isn't going on. So there are hotspots such as the Walmart, the Lowe's, and places like that where the population density increases. And it strikes me that these are, of course, areas where for potential spreading, but are there any specific studies that look at more rural states and then look at these sort of population density hotspots? Have you all looked at that at all?
You know, it's something that we're aware of, but I'm not aware of people who have explicitly modeled this in detail. There are some types of models that are called agent-based models where they try to simulate in great detail individual movements. They would put, 320 million people in the United States and have them go about their business. They can be very misspecified, but certainly I think there's broad recognition in the epidemiological community that it's the places of convergence that are at greatest risk. This is the reason we close a lot of businesses and shut schools and stop mass gatherings. So, the issue associated with essential services stores, places like Walmart, Costco's, grocery stores that are open, those are the hotspots where we have to really put a lot of control efforts right now.